seminar intends also to inform the audience about the upcoming guidance document, which we hope to release in the coming months, and provide a brief overview of the ethical issues that could arise. We will also hear some case studies and hear about how to ethically balance the objective of data collection for public health goals with the obligation to protect the privacy of citizens. Now, we're very fortunate to have three eminent speakers with us today. The first is Dr. Daniel Hogan, who's a statistician in the WHO Department of Information, Evidence and Research. We also have with us Professor Ali Akbar Haghdoost, who's a professor of epidemiology and the chancellor of the Kerman University of Medical Sciences in Iran. He's also the head of the Regional Knowledge Hub and the WHO Collaborating Center for HIV Surveillance. And finally, we have with us Professor Amy Fairchild, who is the co-chair of the Center for the History and Ethics of Public Health at the Mailman School of Public Health at Columbia University in New York. The center is also a WHO Collaborating Center for Bioethics. Each of the speakers will speak for about 15 to 20 minutes, and we will not accept questions after each of them, but instead, at the end, we will have a 25-minute session for question and answers. The people in this WHO library room will be able to ask them orally. The participants joining us by web in the webinar, they should ask their questions in the chat functions, and we'll try and deal with them. So without further ado, I would like to invite Dr. Daniel Hogan to start with a presentation on data for monitoring health in the SDGs. Thank you.
Well, thank you all for coming in, for having me. I'd asked to give just a brief overview from the statistics side of data needed for monitoring the Sustainable Development Goals. And I work in the Mortality and Health Analysis Unit at WHO, and among other things, we provide we clear WHO statistics before publication for methodological rigor, and also help coordinate WHO inputs to the SDG monitoring process. Just to start with a very broad overview of the SDGs, this is part of the 2030 Agenda for Sustainable Development, and the SDG Declaration was adopted by heads of state last September, and it's really been a member state-led process with UN system inputs. And it's a very broad agenda, so it's comprised of 17 goals, of which health is one. And then within that, there's 169 targets spread across the 17 goals, which will be measured by over 230 indicators. So quite a lot of measurement going on to monitor progress. And the SDGs are unprecedented in scope and significance, and so much broader than the Millennium Development Goals, which ended in 2015. And they're meant to cover the economic, environmental, and social pillars of sustainable development, and in particular be applicable to all countries. So unlike the MDGs, which are really focused on developing countries, these are meant to be applicable to all countries and also meant to address the needs of the poor or otherwise disadvantaged wherever they may live. So much stronger emphasis on equity within countries and this sort of tagline of leave no one behind. So in terms of the health-related targets, Goal 3 is the health goal, and there's 13 targets within it, but there's also several other health-related targets and other goals. So looking at this table, we have the 13 targets within the health goal. On the left are really targets that have carried over from the MDGs. So these are maternal and child mortality, major infectious diseases like HIV, TB, and malaria, and sexual and reproductive health. Then in the middle, we have a new area, which is expanding into non-communicable diseases and injuries. So you can think of these sort of new SDG target areas. So we have a target on NCD and mental health, one on substance abuse, one on road traffic, and then lastly one on deaths due to air pollution.
Yeah. Interesting too. You can have these stop seeing.
Okay.
So.
Okay. All right. Yeah, so that sort of middle column of sort of new targets for within this area, and then lastly on the right we have these means of implementation targets focusing on tobacco control, access to essential medicines and vaccines, health workforce density and distribution, and lastly health security. And then sitting over top those targets is one on universal health coverage, which includes indicators both on service coverage but also financial protection against catastrophic spending on healthcare. And then down at the bottom, there's just to mention there's other targets on outside of Goal 3, but are certainly health related. For example, on malnutrition, water and sanitation, clean fuels, urban air pollution, and deaths due to natural disasters, homicide and conflict. So if we think about how indicators for those targets can actually be monitored, we have to draw on a lot of different data sources. In particular, we need to be able to measure mortality, disease incidence, service coverage and capacity, as well as risk factors. And some of the main data sources that we have available include at the top here, we have civil registration and vital statistics systems, which record births, deaths, and cause of death. And this is really the sort of data backbone for mortality statistics, but unfortunately only about 30% of countries in the world have complete systems, so there's huge gaps to monitor these indicators. And second, we have a variety of household surveys. And during the MDGs, I think the demographic and health surveys and mixed surveys really rose to prominence and offer monitoring for service coverage, risk factors, and health behaviors, along with some mortality, largely focused in developing countries and among sort of reproductive, maternal, and child health indicators. So in sort of perhaps unintuitive, we have more data on those types of indicators in developing countries than we do in developed ones, at least in standardized data formats, as wealthier countries tend to run their own surveys, which may collect slightly different indicators that aren't always comparable across countries, or at least aren't readily available to the global community. Then there's also a census, which occur every 10 years and provide information on births and deaths. And then lastly, health facility data, which is sort of picking up speed with the move to electronic systems such as DHIS2. And this offers some potential for monitoring service capacity, but in the future, hopefully will offer ability to monitor mortality and other indicators. But with all this, really important to highlight that there's really huge gaps in data availability for monitoring many indicators. And right now, we've sort of been focusing on national level monitoring, which we have big data holes for. And then add on top of that, with the SDGs, an emphasis on monitoring inequalities within countries. So that sort of explodes the measurement agenda without sort of concomitant explosion in data availability. And then also this issue of data in humanitarian settings, where we often have very little data at all. I want to talk just a little bit about global monitoring activities, since that's a lot of the work our team is focused on, and how that relates to these data gaps. So sort of we term global health estimates. They aim to provide comparable values for a particular indicator, like under 5 mortality rates, across countries and time. And the methods that are used to produce those estimates involve reconciling multiple data sources, which may not always agree, to come up with sort of one best estimate. But they also involve predicting missing data. So if data do not exist, to get sort of a fully rectangular data set, some imputation of missing data is undertaken. And there's really been a huge growth in the production of global health estimates over the last 15 years. And which is interesting, because I think there's clearly value to donors and agencies and advocacy groups to have these numbers, but I think less clear what value there are to countries, which tend to rely on statistics they produce internally and understand. And it's also a bit unclear what role these sort of UN and academic global health estimates will have in the SDG reporting process, because there's a lot of language in the SDGs about country-led monitoring and the use of official country statistics. And I just want to come back a little bit in thinking about country monitoring and think about this idea of predicting data that do not exist and why someone would want to do that. So in the absence, I think if you think about priority setting exercises, if you don't have any other information, then sort of taking a best guess can be valuable in terms of providing some information about the expected relative importance of different health areas where funding could be allocated to. And it arguably is useful for monitoring at regional and global levels. So if you have data on some countries but not all and are trying to get a sense of the general regional or global trends, this prediction of data gives you a way to aggregate up to a global total in a standardized way. But at country level, if you're only predicting data, it doesn't really offer much value for actually monitoring what's happening in the country. I just want to give one actual example of this. These are, last year we published estimates of maternal mortality ratios from 1990 to 2015, and this is the set of estimates for Guatemala, and this is the maternal mortality ratio on the y-axis and time on the x-axis. And so the thick orange line is sort of our final estimate of the change in the maternal mortality ratio over time. And then there's a variety of data sources that have been pulled together to inform that estimate. So I think this is an example of where this sort of goal monitoring can be helpful because we use very sophisticated techniques to make sense of all the different data sources that don't always agree with each other. Then you can contrast that to, say, estimate for Pakistan, which has one data point in 2005. So this is a heavily predicted statistic, and raises the question. Okay, so I guess it declined by 50% over 25 years, but it's based on one data point, and it's largely just based on the sort of regression coefficients in the modeling. And so here's an example where it's not clear what Pakistan should do with that number. It's not very informative for measuring progress. So I'm not an ethicist, but I'll just close with a couple of ethical issues that at least I'm aware of. It's certainly not an exhaustive list related to monitoring some of the SDG indicators. And some are fairly specific. But for example, in some of the household surveys, like the demographic and health surveys, they geocode the survey clusters and the villages, and so you sort of can tell exactly where households are. But they actually scramble that information before releasing the data sets so that a researcher can't take the responses and understand where they actually came from. So it's a privacy issue. But on the other hand, if the goal is monitoring equity and subnational information, if you start scrambling the geographic information, you lose that information that you might potentially make use of to allocate resources to particularly disadvantaged areas. It's also the issue of reporting survey results back to participants and their families. I think one example that's common in the literature is HIV testing and household surveys, and whether or not those results should be shared with the participants, and also if there's any obligation to provide treatment to the participants in the survey once they learn about their positive test result. If we think about civil registration and vital statistics data that are reported to WHO, we sometimes run into issues with small cell sizes and aggregated databases. So even if you have sort of unit record data on individuals that you then add up, so you have sort of total deaths by age and sex, for example. If you have very few deaths, it actually remains sort of individual data. So neonatal deaths in small countries in Europe, there may be years where there's only one neonatal death. And so if you report that to WHO and say that the child died of prematurity, then people would know that that particular actual individual died from that cause. So it's not a major issue across countries, but it is one that we've been dealing with lately. There's also the question of using national ID number for tracking the health of individuals. From a scientific perspective, this would be fantastic, and lots of great epidemiological research coming out of Sweden, because they have this essentially national cohort that's been running for decades with a national ID number that lets you follow people over time. And I guess a more general issue from the statistics side, we're hoping that there's rapid scale up of information systems, but that could happen. If it was to occur quickly, it may outpace the privacy safeguards that need to occur alongside that improvement in measurement. And then at the bottom, just some broader issues our team have been talking about lately. One is around the area of open access data sharing and transparency. So for global estimates, we recently published guidelines led by Gretchen sitting in the back here that requires that in journals people present the underlying data with their estimates so that people understand where they come from. that data is aggregated, so it's not at the unit record typically. But there is a conflict between that potentially, and then privacy issues as well as data ownership issues. And coming to that, where does commercial use fit into these sort of public goods that are being produced by, say, survey teams and the UN system? And then finally, I mentioned this earlier, but top-down versus bottom-up monitoring processes. And I think for the SDGs, it's an open question, or it'll be interesting to see how it plays out in terms of who has the final word on health statistics. Is it sort of official country statistics, or is there another group that sort of takes a look at things and ensures that things are measured in a standardized way? So that's all I have. Thanks.
So you laid out some ethical issues for us when it comes to data collection, but we still might ask this question, so why do we need surveillance guidelines? Haven't we been doing public health surveillance, for some 2 centuries now without any issue? Isn't maybe the problem something different? Should we be having our attention focused on something perhaps more pressing? But I'll just give you the example of, let me go back, I don't want you to see that yet. I'll give you the example of gun violence in the United States. So in 1996 in the United States, there was a congressional legislation that prohibited the CDC, the Centers for Disease Control and Prevention, from tracking deaths by guns. So what this does is raises the questions of the failures to underscore surveillance, and it puts into bold relief this point that sort of the law alone, the legal requirements, legislative requirements, regulatory requirements for surveillance aren't enough, that we need a means by which to judge law, regulation, and practice, and ethics is an important means. As Andrea said, there hasn't been any systematic, overarching ethical guidance for public health surveillance. And part of the reason is that it can be very difficult to distinguish public health surveillance from the research enterprise. On the one hand, public health surveillance is something that's understood differently by different nations. You can get different national definitions of what public health surveillance is. It's not always described as the systematic, ongoing collection of data. And scholars define public health surveillance either broadly or sometimes quite narrowly. Although disease typically figures centrally in definitions of surveillance, in some instances there's a broader way to look at it. It can be the focus of surveillance can be the determinants of important health events and in the environmental conditions that impact health as well. But if you just take the WHO definition of surveillance and compare it to the World Medical Association definition of surveillance, where WHO describes surveillance as the continuous systematic collection, analysis, and interpretation of health-related data needed for the planning, implementation, and evaluation of public health practice. If we compare that to the WMA definition of research with human subjects as aiming to generate new knowledge regarding the causes, development, and effects of disease to improve preventive, diagnostic, and therapeutic interventions, we can begin to see why there might be some question as to how these two things actually differ, what's the difference between them, what kinds of ethical guidelines should be governing each, and should they be different. And in the case of research, there is explicit institutional oversight of data collection, and there's also extensive national regulation and law, as well as international guidance. And consent, informed consent, is the norm when it comes to research. In the case of public health, we have some disease-specific guidance HIV/AIDS is one of the conditions that has elicited different sets of ethical guidelines. We have very few examples, though, of any kind of ethical oversight of surveillance, and the norm is that surveillance is conducted without consent or without knowledge. So despite these definitions, these definitional similarities, there are very great differences in practice between research and surveillance. Both CIOMS and the Nuffield Council on Bioethics have noted that there are ethical issues that are raised in the context of surveillance, and have generally acknowledged that surveillance is important and shouldn't be subjected to the kinds of ethical oversight that human subjects research is subjected to. But they're more than acknowledgments. They're like pins that have been dropped on this map of uncharted territory when it comes to what nations do in terms of the ethics of surveillance. And so that's where this WHO project developing ethical guidelines for surveillance stemmed from, that my colleague Ali and I have been co-chairing for the past 2 years. So we considered public health surveillance as something quite distinct from human subjects research. As we began this process, we thought about the different normative frameworks that could potentially guide an ethics of surveillance. And of course, the traditional framework and the one that guides human subjects research has been bioethics. Which, after World War II becomes a means of thinking about putting the protection of individual people, individual subjects at the center of attention. And so respect for persons and the concept of autonomy have really become the lodestar of bioethics frameworks for thinking about the protection of individuals. In the context of the AIDS epidemic, human rights became a powerful framework for people in public health to begin to reckon with. It is concerned not only with there are many ways to think about human rights, and my goal is not to sort of elaborate a definition here, but sort of it's broadly concerned with the rights and interests of individuals, and it's an important advocacy tool, and it's an important comparative tool when thinking about nations and the kinds of ways in which populations and individuals are treated within broad national contexts. And public health ethics then is something that emerged really in the context of the AIDS epidemic. And in this case, it was population well-being. This is not to say that respect for persons and individual rights were not central, but in the context of AIDS, population well-being became a central concern. And after 2000, there were a number of concerted efforts to articulate an ethics of public health that was distinct from what frameworks we had seen for bioethics, and also from human rights frameworks. And taken from a public health ethics framework, one of the emphases was on the affirmative duties of public health to undertake surveillance. And so this is just a quote from the guidelines that are still in process. Without adequate stewardship from public health bodies and participation from individuals and communities, the benefits of surveillance can be placed at risk. So now there may be debate amongst people. There's a debate amongst the committee that's developed these guidelines about what kind of priority to accord surveillance, what kind of priority to accord population well-being. But in general, I would say that we have been guided by the sense that there is an affirmative duty on the part of states and the part of nations to undertake surveillance. And while we note the need to take special care with vulnerable populations, one of the things we've recognized is that far more common is the problem, not just of resistance to surveillance, but the failure to undertake surveillance and visibility rather than being counted has been one of the problems that we have seen. And so we have fought not only in terms of the rights to limit surveillance, but affirmative rights to be counted. I'll give you just 3 examples. So in the case of the recent Ebola outbreak, one of the things that became clear is we simply didn't have the surveillance data to respond as was needed. A recent analysis of the international health regulations determined that fully 1/3 of countries have made, and I quote here, made no progress in achieving core surveillance capacities as required by the 2005 revisions to the IHR. And finally, to give you an example from the United States, occupational disease reporting in the U.S. has been described as a century behind infectious disease reporting and counting. So the failure to count is one that weighed on our minds just as much as the types of burdens that subjecting populations to surveillance can impose. So what I want to do now is just raise some questions for you that you can take up in discussion. These are some selected examples, and I'm trying to draw across, not just limit them to infectious disease, but to try to draw across different disease domains. So we can take the example of immunization registries. And I know the history in the United States here better than I know it in other places, but it's been hotly contested in the United States. But if we start from the premise, and you can of course challenge this premise, that an immunization registry that tracks children and tracks their immunization status is a legitimate public health function. We could take the example of a comprehensive immunization registry of all children, birth to age 6, that aimed to achieve universal vaccination in nomadic populations. So one of the questions that public health officials might be forced to face is not simply should we do it, but how can we do it? What kind of data can we put in this registry? Can we track, given that this is a nomadic population, can we track using cell phone records and GPS phone data records? Can we track the location of populations so we can find children and make sure that they're vaccinated in a timely manner? And if so, is consent required? Is consent required for what? Is consent required to be listed in the registry? Is it required to be tracked using phone data? Is it required to be vaccinated? So I think these are some of the questions that attend a case like this. We have to, they're the questions. Can we track location, and is consent required? We have to consider issues of dissemination and disclosure in thinking about the ethics of surveillance. So if we take our same vaccine example in nomadic populations, if we were to imagine an outbreak situation and you have very low vaccination levels in nomadic populations, who should be told about that? Should the populations be told? Should the broader population be told? And what kind of care needs to be taken to protect vulnerable populations from disclosures of public health data, information such as this? When we think about issues of, so that's an issue of dissemination of information. If we think about issues of disclosure of information, we might think about a situation in which forestry officials who are concerned with poaching, which is considered a criminal activity in some places, might want access to the data. So if public health has GPS access, can locate the populations, what's the public health obligation to either share those data for a non-public health purpose or to protect those data? And finally, on the communicable diseases front, I would say a broad question would simply be, are there significant moral differences between infectious diseases and NCDs that could and should shape the nature of surveillance? If in the case of infectious diseases, we can say that preventing harm to others gives us a warrant for conducting surveillance without consent, can we say the same thing in the case of non-communicable diseases? So if we now stick within the NCD realm, is it ethically permissible to undertake surveillance when we may not have a solution? For example, if we think about occupational exposure, so asthma amongst migrant workers, migrant farm workers who are exposed to highway exhaust, if there's nothing that we can do to prevent those workers' exposure or to protect those workers, at least in the short term, can we still undertake surveillance? And then we can think about how we might use those surveillance data. Would there be a duty to issue air quality alerts, particularly to populations with asthma who might be considered vulnerable? And what would that mean? Or would we withhold that information? In the United States, there's been a long history of debate, for instance, over occupational disease exposures and questions of whether health officials should be telling workers, if you can't do anything to treat the condition that you've been exposed to, should you be giving workers information that might simply alarm them and upset them, and that they can't act on in any way? So what are the obligations to share information in a case like that? And finally, we might think about the example of diabetes. Can information in a diabetes registry, let's assume you've met the barrier and decided that we can do diabetes surveillance to begin with, could that information be used to track individuals who have fallen out of care? So could you use that information to determine whether or not individuals are getting the routine tests that determine whether and how well they're controlling their blood glucose levels? Could you use that information to reach out to those individuals and make sure that they are in care? Or is the mandate of public health simply mapping the incidence and prevalence of disease only and not actively intervening to make sure that people don't fall off the map in some fashion? So what are the limits of how, not just how we collect data, but then how we use those data? So as we grappled with these questions, we came up with a set of core values, foundational values that have guided the development of the guidelines and the instance of this WHO project. And so the first is the public good, this understanding that population health is fundamentally shared and it can't be reduced to individual goods. Equity and justice, which I'm going to define now simply as the fair distribution of benefits and burdens associated with surveillance, is another core value, as is respect for persons, this idea of individual dignity. And finally, this notion of accountability, governance, the notion that we have governance mechanisms that are open to public scrutiny. And the debate that we've been having amongst ourselves is, how do we consider this framework? Is population good the core, the central core value that has to be checked or limited by values of equity and justice and respect for persons? Or are all four of these values on par, neither having priority, none of the four having priority, that must in every single case be weighed against one another? And that's the debate. That's like my little drawing, simulating sort of the kind of conflicts that come when we begin to answer these questions. And one of the things that we have said in the guidelines is that we're not going to be able to resolve all of these questions. And in fact, there are these two sort of broad frameworks for thinking about it, either sort of starting from the assumption that the public good is the priority, or starting from a level playing field where you have all of these values as equals. But one of the things we write in the guidelines is there can be no easy solution to the tensions that underscore the ethical complexity that public health policy must address. And so in practice, whatever the guidelines end up, however we end up framing it, and I think we will end up framing it in both of these ways. In practice, normative pluralism is going to be what's going to happen when these guidelines are applied in practice. And that's one of the things we hope to stress in this document. So what I want to do do I have a few more minutes, Andreas? I want to just highlight for you some of the key guidelines that you're going to see coming out of this document. The first is going to be the obligation to develop comprehensible, feasible, sustainable surveillance systems. And I'm not giving you the guidelines word for word. I'm boiling them down to their essence. And this is going to be limited by needing a legitimate public health purpose. Informed consent in the guidelines is not the norm. The guidelines recognize that there are times in which informed consent might be imperative, but we note that this is typically not the norm in the case of public health because of the needs of data reliability and validity. But a third consideration is that we recognize that not all countries have the resources to conduct surveillance. I mentioned to you that under the IHR, a third of the countries haven't met their obligations. So the guidelines lay out an obligation on the part of the global community to help sustain and support surveillance in countries where it's not financially feasible. Surveillance involving vulnerable populations is not only permissible, but it's essential. We undertake surveillance in large measure in order to address health disparities, in order to address inequities. And if vulnerable populations don't get counted, they don't count. So while there is a lot of attention paid in the guidelines to identifying harms, accounting for harms, and monitoring for them on an ongoing basis, and then taking efforts to mitigate them, it's still very important to track the diseases, conditions in vulnerable populations. And results too must be effectively communicated. If we don't communicate results to these populations, we remove from them, even in the face of not being able to act to prevent, say, asthma amongst migrant workers who are exposed to road exhaust. We remove from those populations the ability to advocate for themselves and an important tool for empowerment. And as I said, at the same time, we have to take a great deal of care to avoid stigmatization and discrimination when we undertake surveillance and we share the results. And we have talked about the obligations to share for legitimate public health purposes that are, and this is something we were just debating before we went in here, so I'm going to be very careful in how I phrase this. Obligations to share when one agency collects public health data for what's been deemed to be a legitimate purpose, that there's an obligation to share that data with other agencies that can justify a legitimate purpose comparable to the one for which the data was originally collected. And this too would apply to research, that there is in general an expectation that provided that safeguards are in place, provided that IRB approval has been secured, that there's a general obligation to share public health surveillance data for important public health research, but never with agencies aiming to take action against individuals. So there would definitely be some limits to data sharing. The uncharted terrain in these guidelines is this question of big data. Different non-state actors are involved in public health surveillance, such as NGOs, faith-based organizations, private companies, professional organizations, research institutes, funding agencies, and the WHO. And we encounter this problem of blurry boundaries in the era of big data. And by big data, I'm talking about both the volume of data that can be collected now, but also the velocity of that data collection that's producing this constant stream of digital exhaust. And there's a lot of enthusiasm within the public health community that big data is going to really make it possible to confront emerging diseases in new ways, and interrupt foodborne outbreaks, link electronic medical records, and improve collaboration across public health organizations. But there's also a very broad acknowledgement that we need to pay much more attention now to public health ethics. Our new digital lives may contain important information that can facilitate surveillance, but on the other hand, it's unclear that the generators of these data are aware of the range of the potential uses of their data, including the potential for disease surveillance. Let me just focus in by saying that one of the things that anybody who applies these guidelines is going to have to think about is the question of governance. That we are not suggesting that institutional review boards, those have been proposed as one means of governing surveillance. We are making the case that that's not the right mechanism, but whatever people who apply these guidelines do, organizations that apply these guidelines do, they need to come up with some systemic, routine, and searching means of addressing the different issues that public health surveillance raises. And here I list just a few, but the guidelines conclude by really making an imperative for institutions, states, governments to find some systematic means of addressing these issues. Thank you very much.
Let's start with a mathematical question. The product of 2 minus negative number is positive, I think, is it? And 3 is negative. Now I want to discuss about HIV, which is a complex issue, about ethics, which is another deep and complicated issue. After 2 professional speakers against experts, I think the result would be negative. Don't expect to see a lot. By the way, HIV surveillance is a complex task, has different components, covers different subpopulations, collects a lot of information, mostly sensitive data. Just to magnify these issues, I explained the component of HIV surveillance. Biobehavior surveys. We have to collect information about the behavior and biological samples of key populations and general populations. We have to combine routine data from blood transfusion, mother and child clinics, VCTs about voluntary counseling and testing centers. Also, we have to estimate the size of IDUs, FSW, female sex workers, and other key populations. On top of that, we have to know something about STI, sexually transmitted disease. And also, we use the routine data. Combining all these components will create a comprehensive surveillance system for HIV. You know, a lot of complex activities together create a comprehensive HIV surveillance. Key populations: men who have sex with men, injecting drug users, and male and female sex workers by definition are high-risk group, or those who are in higher risk. But depends on the situation in different countries and cultures. Men who are clients of sex workers, mobile, those who have a mobile job, youth, prisoners, street children, refugees, migrants might be accounted as special group, and we have to pay special attention to all these groups. Data collection. Also, we usually use different schemes and methods to collect information. Sometimes we collect information in a household-based survey or facility-based, sentinel sites, Venus-based, mobile centers, convenience sampling. All these data collection schemes may help us to collect required information for a comprehensive surveillance system. What we have to collect? We have to collect information about sexual relationships and sexual behavior, which is a very sensitive issue. We have to have information about drug use, also biological sample and lab tests, demographic variables, social network and the association of subjects in a community, and many extra information. All information is needed to create a good picture about HIV and its determinants in a community. And privacy is a key issue in all steps: data collection, data storage, data analysis, utilization of data, dissemination, and even use this information for secondary analysis. Privacy has to be addressed in all these steps. And potential harm. If we ignore this issue, we may face subjects with physical, legal, and social harms, even medical harms. Therefore, the sequence of this ignorance, or if we don't acknowledge to privacy, we may create a very deep crisis in the community and mainly the vulnerable population. One thing which is a key issue and critical issue in privacy is case identifier. Do we have to keep personal information of subjects? More or less, the response is positive. We have to keep record of subjects to minimize the risk of double counting, to create a longitudinal surveillance database to follow subjects, to link data of cases from different sources, and to provide the appropriate care to subjects. All these reasons force us to create a unique identifier, and this identifier might violate the privacy of subjects. Also, we have to pass, or it is recommended to pass the results of tests to subjects. Both positive and negative results are important. Negative results to the subject may be used for preventive message and services for those who are negative, and positive results may help subjects to be linked to HIV treatment. Now, in these few slides, I try to highlight the importance of HIV surveillance system and the complication which it has, and privacy, which is very important in the HIV surveillance. Now, what we have to do? At least we have to address a few questions in the beginning. Does the program have written policies and procedures on data security and confidentiality in advance? Are procedures in place to respond to breaches in data security in any case? Insecurity training required new staff members and annual for staff members. Are all staff members required to sign a confidentiality agreement in advance? What is the rationale for the proposed data collection? For what reason we are collecting this type of information, which we have to address in advance as well? Have possible alternatives to using identifiers, such as using anonymous data, been explored? Have data dissemination plan been described? What efforts have been made to ensure that non-identifiable data are disseminated regularly in a timely manner? It is also important to pass non-sensitive data to some stakeholders, even to community, and sometimes help to prepare a better scheme for minimize the risk of infection. Ethical issue, there are a lot of ethical issues around the surveillance of HIV/AIDS. Ignoring autonomy of subjects in some step, it is a risk or a hazard for HIV surveillance system. Producing inadequate information to guide public health system, it is another important issue. Sometimes we are collecting information in most of components, but ignoring a few of them. For example, population size estimation is ignored in some countries. They have information about biobehaviors of subjects, risky behavior of population, but they don't have the size of high-risk groups. Therefore, they cannot create a good plan for caring for the management of HIV. Therefore, adequate information is required for all components together to create a good picture. Inadequately considering vulnerable group in data collection and risk related to specific data collection strategies. Issues of inadequately protecting the right to privacy in data reporting and sharing. Issues of inflicting harm and restriction freedom when labeling individuals suffering from health issue, and issues of foregoing public health benefit by not adequately putting data to use. Two obligations we have to address. Every effort must be made to minimize such risks and should ensure that persons placing themselves at risk are referred to appropriate services. Sometimes we are collecting information, but we don't have any service for those who are positive or are in risk of infection. We have to keep in our mind that when we are detecting positives or we're measuring the risk of infection, we have appropriate services after that. And finally, two conclusions. First, HIV surveillance system is a very complex task with different components. And second, ethical issues, particularly the privacy of subjects, have to be addressed in all steps and all components of the HIV surveillance. Thank you very much.
I would like to thank all the three speakers for their very informative talks and open the floor for discussion. Again, those of you who are joining us online should ask their questions via the chat room. Ron.
So you said that nations have an obligation to create surveillance systems. There's a global obligation to support such surveillance systems. The question is, in terms of global priorities, in terms of the demands of many, many different things, eliminating, no HIV cases by X year, no TB cases by X year, maternal mortality. Now, clearly, surveillance is part of all of those, but establishing adequate and effective surveillance systems is not an inexpensive task. So I'm wondering how you would begin to think about prioritization of helping nations to develop surveillance systems adequate to the challenges they face, given competing demands on resources, both globally and locally.
Sorry, Ron. Who was the question? Maybe mainly to Okay.
Did you direct that to me or to Dan?
I think both of you, because
I want Dan.
Yeah, I don't think there's an easy answer. Yeah, I'm not sure what to say. I think it's an important question. I guess part of it should be tied to perhaps what interventions can be undertaken in a cost-effective manner to address those problems. But I wish I had an answer. I think the question of how you go from where countries are now with very little health data to sort of the fully functioning Swedish system, I think like that, mapping out what that should look like, tailoring it to countries is an important exercise that should definitely happen.
Well, and the guidelines talk about this a little bit. Even the guidelines that we're developing don't answer this question. And one of the things that we have to consider too is that the priorities of any given country might not align with the priorities of the global community. So this is always going to involve a process of politics. And I think it just highlights the need to have priorities, to have surveillance set as a kind of fundamental good, and have ethics be given a kind of prominence in addressing these questions, which are fundamentally political, to underscore that there always has to be some yardstick against which to measure the political, understanding that we're never going to agree on how we do that or what those priorities should be.
Okay. Ali, you want to complement?
For sure, the shortage of resources is a big issue in most of countries because surveillance systems. That sometimes, even in the limited resources are spent in one or two surveillance systems and ignore the other parts. It is recommended to create a map and include most of public health in the system. Sometimes they can collect the information in sentinel sites just to address very important issues. I think we have to recommend to pay attention enough to all health considerations, not ignoring one part and sending all sources only one part of the health.
just a way of comment. Someone used to say in the United States about surveillance, there's HIV and there's everything else.
Okay. I think we have a question from cyberspace, which will be read by
Continue a brief comment on that issue that was just raised.
Okay, if it's directly related, yeah.
Related.
Okay, let's first deal with that.
My comments were very general. Two comments. One was about the big data, because we are talking about the public bodies collecting data, but these days with the big data, I think a lot of private agencies, I'm talking about Apple, Google, and etc., are collecting health-related data and behavior. And I wonder if the guidelines have something about this respect and how to deal with that. The second question or comment is about the guidelines is that we are providing the framework for ethical guidelines and directions. Is there any provisions for countries or groups or organizations who don't behave according to the guidelines framework? You know, what will be the stick, the carrot? Sorry.
I don't know what the, you want to take two or do you want to address?
Yeah.
Yes, you go ahead. So on the latter one, one of the things that we have said, I mean, there's not necessarily a stick, but one of the things that we have said is that we want to be very careful that the guidelines don't be read as giving carte blanche to any kind of surveillance effort. And that this is where, so I talked about the different frameworks, bioethics, human rights, and public health ethics. This is where I think it's very important to invoke human rights. That if there are contexts in which they're characterized by human rights violations, systematic human rights violations, it's in those contexts that, in fact, you might want to see brakes being put on surveillance rather than seeing affirmative duties for surveillance. We want to be very careful that surveillance is not used as a vehicle for oppression. On the question of big data, the committee decided that it's an incredibly important issue, and it's one that there was a big meeting in the United States recently in which public health officials expressed a great deal of enthusiasm about the potential for big data to sort of fundamentally transform the practice of public health surveillance. It's a scope and scale that we couldn't undertake it in this committee, but there have been several groups of us involved in this who are we're going to try to launch a separate project on the ethics of big data.
Dermot?
Ron was asking the question, how much would it cost in order to try to develop these fantastic information systems which are our ambition? And I think there are efforts underway as part of disease control activities to try to estimate the cost of setting up good surveillance as part of the overall system for disease control. And one of the activities that I think is really important to ensure that we do, and therefore that we also cost, is actually making sure that we do everything we can to inform people, communities, nations, societies about why we're doing this surveillance. And this can be forgotten. So even recently in the United Kingdom, there's a good example of this, whereby the UK government, led to its research body, the United Kingdom Medical Research Council, had invested a lot of money to set up a system called shared.data, which is meant to provide for the UK what is provided in Sweden. So a fundamental way of using all of that fantastic data, potentially collectible to the national health system, to use that for research. So the head of the Medical Research Council, Professor John Cavill, he said this is a really fantastic opportunity for the UK to improve the health of its nation. And then unfortunately, they didn't really consult adequately and widely enough. They didn't inform the populace of why this is being done. They didn't really discuss very clearly with the doctors in the National Health Service. So in fact, there was a reaction. And the doctors said, we don't really understand what this is all about. And the public said, we're really, really unhappy about this, but there don't seem to be adequate safeguards for confidentiality. And so the government, embarrassingly enough, pulled the plug in July, having spent lots and lots of money. So it's just a salutary lesson that we really need to, in thinking about information systems, do all we can to empower people so that when they exercise autonomy, they're exercising the best possible autonomy they can. You're a better ethicist than I am, or an older one. It seems to me that I'm a that you can really only fully exercise autonomy when you're equipped to exercise autonomy. And if someone hasn't had issues explained, if they're not informed, if they don't understand, then when they ask the question, they can't exercise autonomy. I'm not really thinking about the recent UK vote on leaving the European Union.
So there's a couple of questions from the floor, and there's one from Famush Ali, who's asking the ethical obligations to share data. Who owns this data, particularly when placed in a public domain or shared? How is the sharing of data reconciled with the financial investment, sometimes by private entities, to collect that data? So the question is now on the board as well. And I don't know whether, because Amy, would you like to start?
So it's a complex question, and I would say sort of I would make two distinctions. So there's sharing of data that's collected. I would say sort of separate. There's data that's collected by public health officials, and in general, I would say there is an obligation to share that data with other public entities that have that want to use those data for sort of a legitimate purpose that's comparable to the purpose for which that data was generally collected, with proper safeguards. So understanding that just because you have names, if names aren't necessarily relevant for another agency who needs access to those data should not be shared. It's one of the things that we discussed in the document. Okay, I can't think and read it. But in terms of sharing, once data become publicly accessible, I think to the extent that it's feasible, I don't think we really addressed this in the guidelines that data sets maybe should be made publicly accessible. But with this, public domain data is not something that we have touched on.
So Amy, the question is who owns the data? And the second question I would like to say, going on from what's being asked, is the ethical obligation to share data a blanket obligation, or is it for it's only sharing for particular purposes?
I would say it's sharing for particular purposes. That the sharing has to be justified. And who owns the data? There's and a community wanted access to the data to do their own data analysis to determine whether there was a cancer cluster in their community. And their contention was, it's our data. We, the people, own the data. And I think that's one of the things that entities who collect data are going to have to address. But it's fundamentally, I think it's publicly owned. It's owned by. This is my opinion. It's owned by the people who made it possible.
Any other follow-up response?
And also, we have to separate the pure data from the aggregated and the results of analysis. Sometimes, not always, most of the time, we disseminate the results even in public framework. But the pure data has to be secure and based on some specific objectives and passing many steps, we have to distribute and share it with others.
And?
I was just going to have that, like the Gates Foundation right now is requiring all the Project SIG funds to share their data within, I think, 6 months. I'm going to get the time wrong. There's sort of a little lag, and it has to be shared. There's a commentary in the Lancet, I think, in the last few weeks where I think the medical journal editors have gotten together, and they were going to start requiring all the anonymized but unit record data to be shared from trials that are being published in medical journals. There's a lot of pushback from researchers on that. Part of that is, I think it's probably a fair concern that they need time to, they spend a lot of time collecting these data sets, and they should have a good chance to analyze them very quickly. So what the lag should be between collection and release is
I think the second part of that question really goes to the heart of the big data issue. This is data being generated not by public health agencies, it's being generated by commercial entities or by social media. And it's out there. And the question is, who owns it? And is there an obligation of those who have helped to create that data to share it with public health? Very different from saying, the privacy issues raised by those who have generated big data, using it for commercial purposes seems to be very different from using it for public health purposes.
Yeah, are there any comments on the second question? Let me maybe read it loud again for those who can see that. So how is the sharing of data reconciled with the financial investments, brackets sometimes by private entities, to collect that data? Are there any more comments on that? Yeah, okay. Okay, then we have another question from the web. So this is from Irene Melamed. Is the population in general aware of the importance of keeping the privacy of the information? Is this an issue that really concerns them? Maybe an initial stage of awareness of the issue would be necessary. Thanks in advance and great presentations.
But in some ways, this speaks to the story you were telling about the UK. So much of surveillance goes on without people being aware that it happens. It goes on silently in the background. It's generated by, your doctor takes a test, a lab does the results, and the lab sends the test. In some cases, sends the test to health officials, and you may be totally aware of what kind of health records exist. They have what kind of registries exist that have your data in it. So I would say, in general, people are not aware of surveillance. They're aware in exceptional cases, like HIV surveillance, where informed consent is required, where there's some kind of requirement to notify people about surveillance. But I think that your point is that we don't tell people at our peril that there hasn't historically been a lot of investment in making sure that populations are aware that surveillance takes place and what the benefits of surveillance are, and sort of how and why how might it be something.
There's another question here. Can you please use a microphone?
Hi, how are you? The guideline seems to be, sorry I wasn't here at the beginning, but it seems to be for the countries. How about WHO? I'm Liliana. I'm in IT, but also I like data. So my question is, for WHO, because you were saying that we have to protect not to harm the individual, and I was thinking, okay, so for some countries, having sex, a man having sex with a man is not a problem, and in some other countries, it is a problem. So when we need to present the information at the global level, what do? Do we get the less, I don't know, the minimum factor? I mean, what do? Do we get the less harmful, and we apply that in presenting the data? Or we say, no, for this country that legally is a problem, we will not show whether the person has sex with another man or not. And for this other country that legally is not a problem, we will show that data. What do we do?
Who would like to answer?
I think that's an important question. I think that, as mentioned in my talk, it's sort of the SDGs are supposed to be country-led, or official statistics for the UN report. What happens if a country that forbids monitoring firearm deaths, like in the U.S., for example? So, that really raises an important question. I think is, what are we reporting on, and who are we answerable to? I think that's a question for both there. It seems like we should be reporting what is agreed on as the important indicators.
Did you want to speak?
So one of the things I think that's really, there's not a sort of a concrete answer to that question, other than to say that in those kinds of situations, it's very important to consult with the communities that would be harmed, and to take their concerns and their priorities into account. And I think that way you can help to minimize harm and empower those communities to be part of the decision-making process when it comes to how data will be shared.
So we're pretty clear. In oppressive situations, monitoring, case reporting of cases of HIV related to men having sex with men, in situations where men who have sex with men are politically vulnerable, criminally liable, that we actually are pretty clear that under those circumstances, the moral obligation to do the surveillance indicating the risk factor, which in this case is men having sex with men, actually doesn't exist. And in fact, we actually pretty much say that under those circumstances where surveillance would lead to oppression or sustained oppression, that is not morally justified.
Abba?
No, I think Ron said it very well.
Okay.
My only suggestion was also that these sort of questions need to be considered by the policymakers before they start collecting the data, and to think through issues and to decide that what sort of data will be shared in what form, and what sort of things will be made available to institutions and organizations that need it for public health action, and to make the public aware of what's going to happen. I think that's a sort of a transparency, accountability issue. But that comes much before collecting the data.
There's a question back there. Can you please introduce yourself?
My question for you was one of the last slides about data use, and it says there's a moral obligation that the data has to be used. But who is supposed to be held accountable for the responsibilities if that data is used? For example, talking about, some of our global data collection, which goes on year after year after year, which says things are going bad, nothing changed, they changed in the past 10 years. But then whose responsibility is that on global level data collection? Which countries have committed themselves to resolutions which we work with? And so who is accountable, that those data are used? Otherwise, we'll go back to the same population when nothing has been done with those things. It's just a sort of little question, but I think those kind of things probably would be useful to think about and to highlight why data is important. And then when countries see that, they can see probably where, if you have probably answer my own question. But I think that's really the first of the question about surveillance to me. I don't think there is a lot of resistance to take us seeing this, but just the data use part. We all say that because data is not used, why we do it, but we improve the methodology year after year. We find other ways to fill gaps and then again tell them about the situation. The one thing I would say is that there's a big section of the guidelines on accountability and good governance, and it doesn't answer a question about how do you do it, but it does highlight the importance of thinking through, again, like Avi said, before you begin, thinking through issues of accountability and governance and transparency, and how you're going to follow through the obligations that flow from the multi-structural. Yeah, I think especially now with the SDGs, I think it's very important because as we committing ourselves to monitoring and a certain group of organizations to be committed in, so at that stage, I think should be discussed. Yes, there are goals and things, and different programs are accountable for those, but then they also have their own little goals within there that they try to reach, which may not. So I feel in between this competition or different ways of framing it, the bigger picture of population monitoring and to see some very concrete change in terms of outcome that it's very difficult to see. So yes, I think it's important and it should be taken at the same level as quality of the data and the importance of those, but the use of the data, we're going to be spending this much money in collecting it, then it should be, yes.
Abba?
So just to respond to your question, not really to respond, just to the question, I think a lot will depend upon how much these guidelines, so first of all, the guidelines actually say that that's an obligation to use the data for public health purposes. Then the next question is, how well do countries adopt these guidelines? And that is the challenge for us, to see that we can get countries to adopt the guidelines and to accept, yes, this is the guideline we follow. And I think from them it follows that they're adopting, they have an obligation to take action. So,
but I would just add one other thing. One of the examples that we've talked about is, there's this question, if you don't have the resources to act, it can still be really important to undertake public health surveillance. Anyway, because without that data, then you have no capacity to make the case for intervention. So I mean, it's a delicate question because you don't want to get into a situation where you're always counting and never intervening. On the other hand, you would never want to sort of say the ability to, a commitment of resources has to precede surveillance.
Are there any other questions from the web, maybe?
So can I ask
yes?
Because I was not involved in the last discussion about the guidelines.
Can you also just say your name again?
Yeah. Sorry, I didn't see before. Yeah, Chema Galleta, I work with HIV here in Geneva. So my question is about the guidelines. When are you planning to have it finished and plans for dissemination, so capacity in the countries, what are the plans for the production of the guidelines?
Yeah, okay. So the plan is to finalize them by the end of the year and then prepare them for publication after the new year. But you would get it under for your review. So we'll have at least 2 more cycles of review before publication. But the guidelines the guidelines development group should have them ready about in a month from now, and then send it out for peer review. Well, I think in the next year we'll have to try and disseminate them with countries in workshops, and I think the best modality would be to link up with big disease programs like HIV and TB to try to become sort of a part of their workshops rather than having freestanding ethics workshops for these programs.
Yeah, I completely agree. I don't think it makes sense to have freestanding ethics workshops for people who are not really going to be involved in the implementation of these guidelines. So what we would hope is to be able to have collaboration with technical teams, both non-communicable diseases and communicable diseases, and make this as a part of the work they are doing. We also hope to do some workshops with National Bioethics Committee or something. We have two options, we have two avenues. So we have Global Summit of National Bioethics Committees, and that's where we disseminate getting their time. But I don't think they are one of our facilitator avenues, but not the ones who are going to implement. So I think our best bet is on technical team.
Okay, any more? Good. If there are no more questions, I would like to thank first and foremost our three speakers for their stimulating talks. And then all of the participants here and on the web for the questions and for the rich discussion. I think you've given us some last items to think about in the finalization of the guidelines that we will consider in the group. And yeah, we look forward to the next seminar, which will take place, I think, in the new year. Next year, yes. Thank you very much.